Hi everyone, and welcome to Megsmenopause live Instagram. We will have the amazing Doctor Louise Newson joining me. I have got loads of questions. I've also got a few things that I want to speak to her about. So I will be chatting with her and asking her lots of myths and stuff, and then I will try and get as many questions as you have DM'd me, which is lovely. She's here.
Hi, Meg.
Hi Louise, how are you?
Yeah, good, thank you. How are you?
I'm fine. Thank you so much for coming on, because I know you're so busy.
That's fine. It's fine. Actually, isn't it nice that when we can do all this remote stuff, it's actually really good because we can reach so many people in a quicker way.
Yeah,
So
I totally agree. And
Mm.
this is so easy, isn't it? I mean, it's so quick, it's so easy. Brilliant. So I've got a few things I want to put out there to you, of course.
Okay, yeah.
Just want to clear up one thing. Can you please let ladies know that if you are still having periods and you're perimenopause, that you are able to take estrogen? Is that correct?
Yeah, absolutely. And it's really important. And I'll tell you why there's some confusion, because if you look at the licensing for HRT, so when we prescribe something, obviously we prescribe it because we've got good evidence, but also we look at how it's licensed. And most types of HRT are licensed for postmenopausal women, which, as you know, means your periods have stopped for a year. But when you look at the evidence, we know that the best evidence for improving symptoms, but also our future health, so lowering our future risk of heart disease, diabetes, osteoporosis, dementia, is as soon as our hormones start dropping. So that means for most of us when we're perimenopausal, so we're still getting periods, but they're probably a bit more scanty, or they're changing, not so regular, maybe a bit heavier, maybe a bit lighter, and we're starting to get menopausal symptoms. So we absolutely can. And license, it's really weird because all the products, as you know, we prescribe are regulated, but the licensing, we have a bit of poetic license, if you like, for licensing. So even things like, for example, many medications we prescribe for children aren't strictly licensed, but we know they're safe. So we still give it. So there's a lot, about 10-20% of drugs we prescribe in general practice are not licensed for that reason, but we know there's evidence, and you know, eventually hopefully the license will change, but that's where the confusions come.
Right.
And so a lot of women are told by their doctors, no, you have to wait till you're menopausal, and I can understand why their doctors are saying that. And as we know, the education is not there yet, although we're working on it for a lot of GPs. So they're looking at the license, but we need to look at the evidence, because actually we need to practice evidence-based medicine for everyone, you know, regardless of what we do.
Brilliant. Right. Secondly, I've got a quick one here. A friend of mine has got cancer. It's in a sort of remission, and she just started to have night sweats. So she asked me to ask you what would be the best way for her.
What type of cancer does she have first?
Okay, so she has, okay, I'm going to say this. She has had, I think, 40% of her liver cut out, 40% of her lung cut out, and it's in her colon as well. And she did have a hysterectomy about 2 years ago. She's young. She's younger than me. She's one of my best friends. And she's vibrant and she's doing so well. I mean, she's amazing. But she just called me the other day and said, look, I'm having hot sweats. So she said she'd had her womb removed about 2 years ago, but I didn't ask whether she'd had her ovaries. But
no, well,
I didn't know whether
that doesn't matter. I mean, as we know, even if women have their womb removed but their ovaries are still there, they have a risk of a slightly earlier menopause anyway.
Right.
It's only women who have had an estrogen receptor positive cancer, so that's usually breast cancers, that you wouldn't give HRT to in the first line, although, as you know, some women choose to have it because of the quality of their life.
Yeah.
But so if she's had bowel cancer that sounds like she's spread, actually, yes, of course she can have HRT. Because she's had her womb removed, she doesn't need a progesterone, so she can have estrogen. Now, when you look at the prescribing of estrogen, there is always a thing, even the insert, you know, that comes with the packaging will say
Yeah.
problem with liver disease. Now, that's if it's a tablet estrogen, because it gets it sort of gets broken down in the liver and can affect the liver. If you have it through the skin, as you know, the gel, the patch, or now we've got
Yeah.
a spray as well, it goes straight into the bloodstream. So therefore it bypasses the liver. So she's absolutely fine to take it. And actually it's important because it sounds like she's going through a really difficult time. And
Yeah.
as you know, we can have so many psychological symptoms of our menopause. She doesn't need anything that's going to bring her down anymore. So,
No.
so it's absolutely fine, but her doctors might not realise because there's the differences in HRT, but she can have the gel very safely.
Right. Well, hopefully you know who you are out there. So I hope you recorded this so you can take it to your doctor, because you're so right. Because as we know, a lot of our GPs, it's not their fault, and you do a lot of work, don't you, out there, like trying to reteach,
Yeah,
re-give the
definitely. And
information you have.
yeah, and we've just developed, there's three of us, so Sarah Ball, Rebecca Lewis and Alice Duffy, who you've met before, other
Yeah.
GPs, and we've written and developed a menopause education program, and we're partnering with a company called 14 Fish, which is an appraisal company, but they do a lot of education for trainee doctors, but also doctors, healthcare professionals, nurses, pharmacists. So we're bringing this educational platform online in the next few weeks, and that will access
Brilliant.
tens of thousands of doctors. So we're really excited about it getting live. So
That's what we've
it's
been
going to be
waiting for.
cheap, it's going to be accessible, it's going to be really easy for people to access, because as you know, as you've learned so much about the menopause, you know that a lot of it is very safe medicine, but there's a lot of confusion out there. But once you've dispelled those myths, look at the evidence, you realize actually how safe it is. But also you can imagine for doctors it's a very rewarding job, because it's not nice seeing how awful women are when they often arrive because they've got so many symptoms.
Yeah.
But as you know, if you get the treatment right, you're not only helping the quality of their lives, but you're improving their future health. And as you know, for your bones, your heart, your brain, it's so important that we live fulfilled lives. You know, we all want to live long, but we want to be healthy, don't we? We don't want to end
absolutely,
up with
of course. Yeah, because it's like me, I had no idea until I came up to the Newson Wellness Centre. Everybody, last menopause day, last October, and I did my DEXA scan up there with Professor Reed and you, and you know, just by using extra estrogen and doing the weight bearing exercise, in 1 year I turned around from being in the red to being on the border,
which is amazing, isn't it?
Which just shows you, you know, for, you know, my mum had passed away, and, you know, of osteoporosis, so I was full of fear around osteoporosis. And then I'd had osteoporosis since I was 49, so you know, 48, and then I was 53, so I had it for all that time. It wasn't like I'd only had it for like 3 or 4 months. I'd had it for a good 4 or 5 years, and then managed with the estrogel and the weight training, and of course a healthy diet and not drinking and not smoking. Of course you have to take all this into consideration, ladies, but I managed to get out of that and into a healthy range, which then just was like, wow, because, you know, my mum suffered. I mean, it was awful. I mean, all her, the bottom of her spine fractured. And, you know, that's one of the side effects, you know, osteoporosis.
Yeah, absolutely. And I think the problem is osteoporosis isn't talked about very much because, as you know, initially it doesn't cause symptoms. And so we know that around 1 in 2 women over the age of 50, if they're not on HRT, will develop osteoporosis, and 1 in 3 will have an osteoporotic hip fracture. And it's not just hip fractures like, you know, with your mum, it's the spine. It affects the way you digest food, the way you move. A lot of people are in a lot of pain, and prevention is better than cure. We've got a treatment. And actually, when we were talking about licensing of HRT, a lot of HRT is licensed for the treatment of osteoporosis. Yet if you see an osteoporosis specialist, they haven't been trained in HRT, and they'll think there's more risk, so they'll give you some of the other drugs, which obviously can help, but they're not going to help with your menopausal symptoms. They're not going to help with your heart disease risk or your dementia risk or anything else as well. So hopefully we can drip feed information so people realise. But osteoporosis is a really big, important disease that's often neglected for so many reasons.
Yeah, they call it the silent killer, don't they? Because
absolutely.
you absolutely usually do not know until you've had a fall or a break or a fracture. And then, like my mum, it just became, you know, she fractured, I think it was her lower spine, and then she was bedridden, and then after that something else happened, and then it's like a domino effect once you get there.
Well, that's the problem. People don't realise. One of my patients told me recently that her mother was carrying the washing down the stairs and tripped and sadly fell and broke her neck because her neck bones were so weak, and she's now paralysed from the neck downwards, and she's only in her 60s. She had an early menopause, never had HRT, and you know, obviously that's very extreme, but you don't know what your bones are like until you've had a DEXA scan or you've had a fracture. So
yeah, because like me, I had no idea. I mean, I did not know that you know, that I had it until I basically, you know, went and sort of told a few lies to get mine on the NHS.
I mean, if someone's had an early menopause, they've got strong family history of osteoporosis, they've got other risk factors, for example, they're taking steroids, medication, then they should be able to get it on the NHS. But often people can't and have to have it privately, but it's also worth saying if people are going to have it privately, they have to make sure it's reported on properly. And this is something that we've both learned from Professor David Reed, who works very closely with the Royal Osteoporosis Society, because the reporting is really important as well. It's
the way that you're lined up.
Pressing a button.
And also he told me always to try and go back to the same DEXA scan machine that you had the time before. So I will be back to you in October to redo it and
well,
have a look how we're doing. I will be back, because you have a DEXA scan machine, don't you?
Yes, we do. We bought one. Obviously the clinic's closed, so we're doing virtual consultations, but as you know, it's open procedure. It's very easy. You just literally
so easy.
When I was having mine done, you have a pillow.
It was just you're in, and you don't really, and it's nothing like an MRI, ladies. It's nothing like that. You're just in. I think you just keep your clothes on. I kept my clothes on, and then you just basically aligned your hip up with like a sort of brick, and then it was just the light came over and the light went. It was really easy. And you know, and also it's not a really expensive scan as well, is it?
I mean,
it's not.
It's relatively speaking. I mean, ours are fairly expensive because obviously we pay for David Reed to do a really good report. You can get cheaper ones when we've looked into it, but they're very much not individualized advice. They're not reported by an expert. So it's like anything. You have to just see what you're spending your money on. And as we know, anything associated with the menopause, there's a lot of monetizing going on. So you just have to be careful what you're spending your money on, definitely.
Of course. But it's one thing I would really want to push out there is, you know, really, ladies out there, really keep an eye on, you know, think about this, you know, and if you can possibly get a DEXA scan, you know, like me, I was 48 when I did mine. So, and I was already in the red. Now, I wouldn't have ever thought I was at 48. So I just want women to, you know, to be quite aware of this, because I mean, I was so shocked when the report came back. But I've got a few questions for you. So I better get these out, because we've never had so many DMs. Right, okay. I'm going to ask a couple, then I'll come back and chat again. Some of these, estrogen. Wanted to know about taking my estrogen vaginally. Okay. Want to know if it's safe and lessen side effects, tender boobs.
Okay, so Progesterone is the body identical micronized progesterone. It comes as a capsule. In fact, I've got some here so I can show you what it looks like. It's like a tiny little capsule, and it's taken orally, and it's the same structure as the progesterone we produce ourselves. And if a woman still has their womb, they have to take a progesterone to protect, because otherwise estrogen can cause a build-up of the lining of the womb. Now, most people find that they quite like taking it. It helps them sleep, so they take it at night time. They feel a bit more relaxed. But about 10-20% of women find that it makes them feel a bit PMT-like, a bit bloated, a bit irritable.
Yeah, I've heard that.
Like it, yeah. So what you can do is use the same capsule vaginally. So you just insert it up your vagina. Yeah.
I've never heard that. I've learned something new today.
Again, this isn't isn't licensed, so it's off license, like I said at the beginning, no ways. But we know from research that having progesterone vaginally, it will protect the lining of the womb, and because it works locally, you don't need as much. So there are two advantages if someone's got some side effects. Firstly, you can use half the dose. So if you're, for example, taking one orally every night, you can use one vaginally every other night, so you can miss out a night. So you have less dose, but also you can imagine if you have it orally, it gets digested, it gets broken down. It affects the whole body. Whereas if you use it vaginally, because it's like a jelly-filled capsule, the sort of jelly bit comes out and just gets absorbed. So it doesn't go all around the body in the same way. So a lot of people find that it's a lot better. Now, there are some Utrogestan pessaries available in the NHS, which are 200 milligrams, and they come with an applicator, and they're used for fertility treatment. So a lot of people get confused and think they can't use the oral 100 milligrams. So then they're using the vaginal 200 milligrams, and that's double the dose. So you just have to make sure it's the same. I know it seems a bit weird using an oral capsule vaginally. Sometimes if people don't like the idea of using the capsule, there's something called Cyclogest, which again is a pessary used for fertility, and it comes as a 200 milligram, but you can cut it in half because it's a pessary. And so people can use half of that to make 100 milligrams every other night. So, but if you're getting to that level, then it's worth speaking to a doctor who specialises in the menopause to make sure that you're having enough estrogen, enough progesterone to protect the lining of the womb, because some women, as you know, use progesterone creams, but we know they're not absorbed enough to protect the lining of the womb properly.
I mean, also I hear a lot of people when they tell me they use progesterone cream, they do get bloated.
Yes, it gets absorbed. It gets absorbed in a different way, and there's just not good data that it protects the lining of the womb. So most of us don't need progesterone. If you've had a hysterectomy, you don't need it. Some women like it, and you can still take it if you've had a hysterectomy. But most women, you know, you don't need it as a hormone. You need estrogen, okay? Most of us need probably testosterone as well. But estrogen is the hormone that will improve your health, improve your symptoms mostly, not the progesterone.
Brilliant. Why am I bleeding for the second time in a month while taking estrogen and progesterone body identicals after 9 months of no bleeding?
So bleeding is really common, and actually it's the commonest reason why people stop taking HRT, because as you know, the best thing about the menopause is not having periods. So if you suddenly get bleeding, it's like, what the hell, you want to stop? So if you start HRT, in the first 3 to 6 months, you can quite commonly get bleeding. It can be heavy, it can be irregular, it can be a real nuisance. And we usually say just try and sort of almost grin and bear it. Every time you change HRT, so if your dose increases or your progesterone type changes, or you change from a patch to a gel, you might get bleeding. So again, if it persists more than 3 to 6 months, that's when you need to be more concerned. So if this lady has had some bleeding after 3 to 6 months, then we need to see as doctors, firstly, is there another reason? So people can have polyps or fibroids or thickening of the lining of the womb. So we need to make sure there's no other reason, because it's always easy to blame HRT for everything, but often, you know, it's not the only cause. So often if someone's been longer than 6 months and they've had bleeding with no reason that we're aware of, then we often do a scan, might refer to a gynecologist to have some more detailed investigations. If that's all normal, and then we can blame the HRT, sometimes we then change the type of HRT.
Brilliant. Okay, I've got 2 questions here. Hey, 2 questions for Dr. Newson. If estrogen is causing water retention, what can I do? I've noticed the stronger the dose, the bigger my belly and hands are swelling. Also increased estrogen, was feeling a bit hot at night, but seemed to be having fatigue and nauseous. Is it because I'm taking too much estrogen? I'm on estrogen only due to surgical menopause.
Okay, mostly it's progesterone that causes the fluid retention, but some women find that estrogen can, and we're not really sure why. Through the skin estrogen rather than tablet estrogen is better, because when you have a tablet estrogen, because I've said it affects the liver, people can sometimes get some fluid retention then. So if they're on a tablet, they should change. But some people find that, for example, a gel causes fluid retention, whereas the patch doesn't. or vice versa. So it's worth changing the type of estrogen. We also know, as you know, some women need testosterone to help their mood, energy, concentration as well. And so
Yeah,
some
very
people
important.
find that they feel better when they've got the balance of the estrogen and testosterone together.
And
So
also
slowly
you do the feminine, what's it called? The
it's called androfem.
androfem. Yeah, you do
yes.
that, the only woman's testosterone, don't
Yeah,
you?
the problem with testosterone is that it's not licensed for women.
No.
And I know I said beginning we prescribe things off license, but there's nothing we can give to women on an NHS prescription, which is absolutely outrageous that we're not allowed our own hormone back. You know, can you imagine frustrating a man and say, look, we're going to get rid of your testosterone, but you can't have it. And
you can't have it. No.
And as women, we produce more testosterone than estrogen. So
no, I know.
It's actually madness. So we're doing some work to try and change that. But so
Brilliant.
There's two ways of getting testosterone as a woman. You can get it on the NHS, but it has to be the man's preparation because that's all there is available. And then it's obviously off license because it's given to a woman. Now, if someone does that, you have to make sure that the doctor knows what they're doing. So they have to do some blood tests. They have to be giving you the right dose, because I've seen all sorts of awful things where people have either not been told or given too high doses, and no one wants to grow a beard or moustache or
of course not.
Problems. So just be careful if you're getting the men's type. So we prescribe androfem, which is this pink cream, so it's lovely pink cream, so it's very, but it's a regulated product, so we know what it is. Every tube I prescribe has got the same amount of estrogen in it. It's actually made in Australia. It's called androfem, and we're allowed under the regulatory authorities in the UK to prescribe it privately. And now it's expensive. Each tube is 80 quid, but it will last about 100 days. So it works out about 80p a day. So a lot of women choose to carry on taking it. And there are health benefits. It can help strengthen bones, reduce risk of heart disease as well, and probably dementia too. So
I think it's because you need to do all your, I mean, you know, we've got estrogen, progesterone and testosterone. I mean, it's like, why put only petrol in the car and not put the oil in? It doesn't make sense.
It doesn't make sense. And there's a big movement with all the menopause societies worldwide. They've produced a global consensus statement to say that we should have testosterone licensed. And I mean, I'm hoping post-COVID we can get back on to really campaigning for it. And
I'm with you on this.
It might have to be campaigning from women rather than from doctors, because actually a lot of these regulatory authorities will listen to women more than they'll listen to us as doctors.
Yeah, I know, because I know Liz is really wanting to do it. She said she's going to chain herself to the House of Commons.
Well, I think you all should. You, Lorraine.
I know, all of us should do, because I cannot believe that, you know, every woman in this country is going to go through it, but we can't get what we're, you know, to have it back. I don't really, just can never get my head around why your GP can't give you the testosterone, or even they don't even have androfem. Okay, I know it's quite an expensive testosterone, but still, you know, we've all paid our taxes. We're going through something that everyone is just going to go through. We should just be allowed to have these to put back in our bodies so that we're better mothers, not actually better, but that so we can actually, you know, live life to the fullest at this age and not be crippled with anxiety and no sleep.
The other thing is we can give back to society, and as you know, a lot of women, because they've got brain fog, poor concentration, anxiety, fatigue, they give up work. You know, they don't have that same fulfilled life, which is wrong.
Yeah, and you know, we see that marriages break down. You know, your relationship with your teenage kids. You know, I mean, it affects everything. I mean, you know, first-handedly being there, I just know that, you know, it took a good chunk of 5 years of my life away, you know, just being on antidepressants and not knowing what was going on, and you know, and just going back and forth to GPs, and then discovered you. Right, let's have a little look. Question for my Insta Live, for your Insta Live. My mum went through early menopause at 45 to 46. So does this mean I'm likely to experience the same? I've just turned 40, so expecting to be perimenopausal soon and wanted to prepare myself. Thank you, Vicky.
great that she's even thinking about it, because this is what
Yeah,
want.
this is where I love it,
really
that,
do
you know,
better.
when
And
40-year-olds
I'm
are
hoping,
reaching out.
you know, I'm hoping when we're old and grey, you know, the generation below us, so yeah, don't look too closely at my roots, but,
I
but
know,
when we're greyer,
I used to be blonde.
I know, but we want people to be thinking more about, you know, before, you know, the perimenopause. We don't want people to be postmenopausal for years, giving up their jobs and their lives. So we don't know, there's no way of knowing when someone's going to be menopausal without a crystal ball, which clearly we don't have. But if people have younger members of their family who have an early menopause, especially around 40 or under the age of 40, it's more likely. So say, for example, if your mother, sister, auntie, cousin all had menopause in their late 30s, early 40s, then the chances are you'll have an earlier menopause. It doesn't always follow, but it's worth. So the important thing is to track your symptoms, because as you know, the symptoms are so vague and so numerous, and you know, symptoms such as fatigue, memory problems, low self-esteem, joint pains, headaches,
Yeah.
we can put them down to so many other things. So we recommend, you know, on my website menopausedoctor.co.uk, there's the if you search questionnaire, there's the questionnaire that we use, and then when our app, you know, our Balance app is coming out next month, which is very exciting, you can track the symptoms then. And so I would recommend that every woman really in her 30s, 40s, every few months just puts you know, marks whether she has any of these symptoms, and if they change,
of course,
because that's the important thing. You know, we can all be irritable and moody and tired, and if it's been like that forever, then that's fine. But it's when it starts to change, and then you think, oh, hang on a minute, are my periods changing? Have my periods stopped? Have I got a Mirena coiling or had a hysterectomy? Maybe I won't know what my periods are doing. But if I'm getting these symptoms, then actually I need to start thinking about my hormones. So that's a really good sign. You can't have a blood test, as you know, to diagnose the perimenopause or menopause.
You don't read a question here. People think testosterone is all about libido, but for me, it totally got rid of awful brain fog and not being able to think of words and stopping sentences. Yeah, well said. It does help, doesn't it, as well, with the brain
Absolutely.
fog.
I mean, it's the way that we're allowed to prescribe it. The nice guidance say that if a woman has reduced sexual desire despite being on HRT, we can consider testosterone. But actually, we really find that it really improves with memory, concentration, you know, that whole sort of emotional energy. People just feel happier, you know. I got
it gives you that sort of oomph again, doesn't it?
I was just resenting everything for a while, and even just emptying the dishwasher or putting a load of washing on, I couldn't be bothered. It was just all a big effort. Whereas on testosterone, everything's just a bit easier, and my memory is so much better than it used to be. So
also, is this is it that if you've got a loss of libido and you take in testosterone, were you saying to me once, if it doesn't work after 6 weeks or 6 months with the libido, then it probably won't work? Is that correct?
Yeah, it's usually about 6 months.
Okay.
It can take a little while to have an effect. It's very important that women have enough estrogen on board as well. So a lot of women contact me in the clinic, so I just want testosterone because I've heard it's so good. Well, you have to have estrogen first, otherwise the testosterone doesn't work. It just gets converted to estrogen. And you know, with libido, it's not just a hormone. There's so much. Of course
not.
You know? But it's one piece, and actually, it's not so much the actual libido. It's more that women feel better, and they can exercise better, and they can sleep better, and they feel better about themselves. So it's not even about sex, it's just about holding someone's hand or feeling a bit more
being intimate, isn't it?
You know,
I just think it's really important to be intimate, and I think people just sort of forget about that. Okay, anxiety, it took over my life. I've been to every doctor and even been put in a psychiatric hospital. Been on Sandrina gel. Does that make sense to you?
Yeah.
Sandrina gel, 2 years on low to high dose, but it hasn't helped with any symptoms. Told to go back to my psychiatrist. He's changed my antidepressants 3 times, no change. I feel so alone. Sorry for the long post.
Oh, what a shame, poor lady. Well, we know that anxiety is really common, and people often get this sort of sense of impending doom. They wake up feeling really anxious, and that's often when estrogen levels drop. And you know, it's Mental Health Awareness Week this week, isn't it? And
yes, it is.
How important it is. And You know, there
Yeah.
are lots of people who have anxiety without being menopausal, clearly, but there are a lot of women who are misdiagnosed and people don't think about the hormones. And we know that the hormone estrogen and also testosterone can really improve anxiety. So
Yeah.
sometimes we don't know. The only way of knowing is by treating women with hormones. And then we often monitor the blood test, because this lady's on Sandrina, the estrogen gel, but it might be she's not on enough. And so measuring her level to see if she's absorbing it would be useful. Also adding testosterone can make a difference. And then it's looking at other things. So obviously her diet's good, but we need to make sure there's plenty of probiotics, because we know that helps serotonin, the happy
Yeah.
hormone. Magnesium supplement can often help. And some people need antidepressants as well. But as you
Yeah.
know, antidepressant isn't the treatment that should be given first line if anxiety and low mood are associated with the perimenopause and menopause. You know, obviously the two can happen together. So some people do need both, but it's
Yeah.
often, you know, hormones make a huge difference. And we see so many women who have had suicidal thoughts, they've had
Yeah.
crippling anxiety, and it improves with hormones. And even within the first 3 to 6 months, you notice an improvement, and then you can maybe change the dose a bit
Yeah.
or optimize.
Yeah, that's what happened with me. And there is, you know, there's no shame about having to take antidepressants if
Absolutely not.
you know,
No.
at all, because, you know, I did for a while, and, you know, and that's why I talk about it quite openly, because the stigma that goes with that, as well as the menopause, you just feel that you're very alone, and that, you know, God, I don't
And
want
it's
anyone ever
very
to notice.
important. And you know, treatments such as CBT, cognitive behavioural
Yeah.
therapy, can help. And actually, for a lot of women, just having the information to know that it can be related to their hormones, it's not their fault. You know, it's and important for family members to know as well, because it's quite scary, isn't it, watching your mum or your partner change, and they're sort
Yeah.
of out of control. So having the knowledge, but having the knowledge before it happens is better, because as you know, when you're in it, you know, I couldn't even remember the dose of paracetamol, let alone, you know, how to manage my life. So
Yeah.
to then get information is too hard. It's information overload. You want to try and be prepared, which is so important.
Yeah. And this is, you know, like for me, I was already so in it that, like, you know, I really couldn't see any way out, you know. And also the other thing, which a lot of women, I know they still do this, is because this is what I was thinking at the time. I was thinking, right, I'm going to hold on as long as possible before I take HRT. I am going to wait till I'm 55 or 56, because I think I can only take it for 5 years and I want that. So I'm going to wait and wait and wait. And then, you know, and then all of a sudden you're like, do you want to get old quickly, Meg? Do you want to lose the collagen? Do you not want to have the zest for life? Do you want to lose your libido? Do you want to feel like this? And it was like, no. And then I was just like, you know, if I had discovered this or knew this when I was 45, I would have started taking estrogen, even when I was still having my periods back then. Well, I was on the Marina coil, so I didn't have them, but I would have started looking in. And I think it's all about prevention. And women out there, you know, you can get in touch with Louise Newson at she has lots of great doctors there. You know, you can have appointments. I would all start like this lady of 40 to start thinking about it now, because it's all about prevention, isn't it? Protects the heart, the bones,
Yeah, absolutely.
dementia.
And it is so important. And you know, that's why you're so fantastic doing what you are with your campaigning and everything else. But it's sad just to hear that you've suffered, and women
Yeah.
suffer all the time. And I think because of the misinformation, people think, well, I'll battle through it. But actually, we know that it's not just about symptoms, it's about this long-term hormone deficiency. And if I
Yeah.
said to you, well, you're deficient in iron, you would say, well, where do I get my iron tablet from? Or if your thyroid gland is underactive, you wouldn't wait for it to have stopped working. You'll start taking thyroxine. And if you were diabetic, you would start taking insulin. And so we are not designed to live on this planet until we're 80.
No.
We used to die in our 50s. So
Yeah.
we need to think that it's actually it's helping, and also we can take it forever. We don't need to stop at a certain age or a certain time. So the earlier that we take it, the better. But if people are listening and it has been many years, they can still take it.
Yeah, of course.
And on my website, one of the fact sheets that we've written is under resources. If you look at fact sheets, there's one about starting HRT when you're older or you've had a longer time since your menopause, and hopefully people will find that reassuring.
So you have lots of ladies that, like, right up to the age of 80. Do you have older women?
Yeah, we do. We often see parents actually, so mothers of our patients, because they've looked at their daughters who are in their
Yeah,
50s really improving, and then suddenly saying, well, I think I would like to try. But also a lot of women have been misinformed and told that they have to stop taking HRT at a certain age.
yeah,
So women often are told that they have to stop when they're 60. And there's confusion here, because we know from evidence that the best time to take HRT is when you're under the age of 60 to start. But that doesn't mean you have to stop when you're 60. And so
yeah,
that's why a lot of people are told, oh, come off it when you're 60. Of course you don't have to. You can carry on, because as soon as you stop taking HRT, that's when your bones will weaken. That's when you're more at risk of
yeah.
heart disease and dementia and diabetes and obesity. So women often come in their 60s because they've been given wrong information.
But it is also like banging our head against a brick wall. I mean, I remember speaking with Diane, I think it was when I was up at yours at World Menopause Day, and it was something about all the GPs in Milton Keynes had like got together and decided that they weren't going to be giving out
Yeah, and
HRT.
the
And
problem is this, it's the misinformation to GPs. So there are some regulatory authorities who have been misquoting old evidence, and they've been saying HRT causes breast cancer. We can't prescribe it. We have to give a low dose for the shortest length of time. And that is based on partly this paper that came out last year in the Lancet,
yeah,
and older studies. And this is looking at older types
yeah,
of HRT. And also we have to look, it's not just about breast cancer risk, it's about the benefits. And so most women are going to die from cardiovascular disease. Most women who've had breast cancer are going to die from cardiovascular disease, not from breast cancer. And there's never been a study that showed that women who take HRT have an increased risk of death from breast cancer. They might increase their risk in a small proportion of some types, not all types of HRT,
yeah,
but actually they might have had it anyway. And we know 1 in 7 women get breast cancer, so therefore 1 in 7 women taking HRT will develop breast cancer unrelated to their HRT. But we need to look at the reduction of risk of heart disease, osteoporosis, dementia, all these diseases, and even
yeah,
bowel cancer. You know, women who take HRT have a lower risk of bowel cancer. So, you know, and also it's about choice. You know, even if there was a higher risk than we are told, actually I would still take HRT, because I couldn't work without it. I couldn't
no, nor could
function.
I.
And I, like you, am worried about osteoporosis as well. So, you know, I cross the road and there's a risk a car could come. You know, I
Yeah,
used to go before COVID on aeroplanes knowing that there could be a crash. You know, we take
yeah,
risks in life. Every time we get in our car, there's a risk, but actually we've got benefit because we're making a journey or we're doing something. So it's the same with HRT. Every medication has
yeah,
risks. Even if you look at paracetamol in the insert for patients, there's this
yeah,
long list. So, but actually, as women, we're allowed to make choices. You know, becoming pregnant has a risk. We know people
of
die in
course,
childbirth,
yeah,
but we all, well, not we all, but you know, some women have pregnancies. We all do things that are a bit risky. As long as
yeah.
we know what the risks are and know what the benefits are, that's fine. You know,
Yeah,
so
well, I'm with you. I mean, the benefits outweigh any of the negative stuff that I've read about. I mean, I got my life back, and I, you know, was in a very dark place. And I know there's lots of women that feel like that. And I was in such a dark place. I didn't think I was going to come out of it. I mean, it was really, really bad. And, you know, and then all of a sudden it was just by rubbing on some cream, some estrogel, some gel, just taking the estrogen, taking the progesterone. Within 2 weeks, I was feeling, you know, started to feel back to the Meg that I had lost for many years, you know. And also I do remember, even you being the menopause specialist, you had to have it pointed out to you, didn't you? Your daughter pointed it
absolutely,
out to you.
yeah,
You know, because when you're in it, you can't
well,
really
you don't
notice.
see it. And it was at the time that I was just opening my clinic and I was writing my website. And as you can imagine, there's a huge amount of information on the website. So it took
Yeah,
some time up. Well, I was trying to be up because I work a lot in the evening because I've got 3 children, as you know. And
yeah.
I kept saying to my husband, God, I feel like I've been drugged. I'm so tired. This is awful. And I was just so irritable and forgetful and just horrible to be with. And then I'd have back-to-back migraines, and I had a couple
Oh
A
no.
real good
Yeah.
sanctuary for me, and I found my joints were stiff, my muscles were sore, and I'm writing all this information on my website talking about all the
Yeah.
symptoms, and I had them all, but didn't even, because I was 46 then, and
Yeah.
it was only my daughter one day when I was shouting about her to her because she hadn't gone to bed, and she said, "Mummy, I think you need your period." She said, "A lot of my friends are like you. Just before their period, they get really cross." And that's when I thought, "Oh my God, I haven't had a period for months." And
Yeah, you don't
you know,
think,
it's
do
so
you? I
obvious that
didn't.
you don't know. And I think, well, if I had my app
Yeah.
and could put in these symptoms, and then it would say, "Have you thought about the perimenopause? You know, what about?" But then you see, I had a struggle because my own GP isn't very happy about HRT, so I couldn't get
Yeah.
it from her. I had to go privately, and you know, I can see why it's a real struggle. But actually, if I had been stronger, I would have gone back to the GP and said, "No, look,
Yeah.
actually, I've
Like we tell them
read
all to do
read the
now.
book.
Yeah.
I've you know, I've read the nice guidance. Actually, this is what I
Yeah.
want, and this is what I don't want people to be all coming to my clinic. I mean, my clinic, as you know, is private because I can't get a job in the NHS. There isn't enough
Yeah.
money for NHS menopause care. But actually, with the education we're doing with GPs, we're helping so that GPs can have more confidence to prescribe HRT. So women should be able to get it from their doctor or sometimes their
Yeah.
practice nurse as well.
Yeah, I'm exactly the same. The reason that my website is there and it's all on there is because I want women, you need to go in there armed with your information. Do you know what I mean? I also have my app, Megsmenopause app,
Yes,
which
yes.
also you can take in, you know, the app as well. It's got the tracker on now as well. So it's exactly the same as that. So you can use the app, but you can go in, can't you, with the knowledge of from your website, my website,
Yeah,
and go
absolutely.
in and don't feel, because it's like, I always think it's like when you go to the doctors and you've got your 8 minutes, it's like, you know, when you're in the hairdressers and they're cutting your hair and you just don't say no, you just sit there and they're cutting it shorter and shorter.
Yeah.
Why do we not have the power? Now we give that power to the doctors as well.
Absolutely, and I think, you know, gosh, we are okay. We're doctors, but we're not God. We're not
No.
paternalistic, and our education, the way that we learn as doctors, has changed. When I was at medical school in the 80s and 90s, it was more paternalistic. You know, we would give the patients the treatment that we thought was right. Whereas obviously that's changed, which is really important. We have to share the decision making. We have to listen to what patients want.
Yeah.
And we have to respect their decisions as well. And this is no different for menopause care. But I know myself, I get very nervous going to see a doctor. I feel like I'm wasting their time. I know they're running late. They've got far more important things to do,
Yeah.
more ill people to see. But actually, we can really help them. So if we, download the questionnaire or track our symptoms, we're learning and we know the information. We can then say, look, I've read this, this is what I want. And then that 8 minutes actually is a lot quicker because they're not having to ask loads of questions and work out, are they depressed? Have they got fibromyalgia, chronic fatigue? Have they got a brain tumor with their headaches? If they can just present it as a package almost to their doctor, it then makes it a lot easier. And if the doctor doesn't know, what they should be saying is, look, I'm sorry, I'm not confident prescribing HRT or helping about the menopause, but this is the person you should see, or, you know, come back and I will learn. And we can't, it's not good enough for a doctor not to know about the menopause because it affects half the population. It's such an obscure condition. So
because you can always, it's like, you know, you, and also like you always say as well to women that, you know, go back to the reception, and if you're going in there, ask if there is a doctor, a menopause specialist within the surgery. And also, if you're not happy with that one doctor you see, you can always go back and ask to see another GP, can't you?
Absolutely. And
just don't make them your higher power at this thing, you know.
A lot of patients think that their doctors would feel upset if they, you know, if they knew they'd seen a colleague or someone else, or even if you saw a gynecologist, for example, in the hospital and didn't get the right advice that you were hoping. Doctors don't mind, you know, we've got very thick skins. We're not there. We want the best for our patients. And actually, if a doctor doesn't want the best for their patients, then I would question why they're becoming a doctor. This is why, you know, we want the best. And actually, I don't know everything. I pretty much know a lot about the menopause, but I'm learning all the time. Even, you know, this association with COVID-19 and estrogen, this is all new, but it's really exciting data. But we have to learn, we have to move on. And so it's important that our patients come first.
Absolutely. Well, Louise, it was fantastic to have you here today.
Thank you for inviting me,
And
Meg.
it was so good. How's all your family? Everyone really well?
Yes, they're a bit frustrated. My middle daughter was supposed to be doing her GCSEs and they've been cancelled.
Oh,
So
no.
she's pleased about that, but she's a bit in limbo because it's a bit of a weird time. And my
Yeah.
nine-year-old is being homeschooled but being neglected by me because I'm working so hard. But she's very motivated, so that's good. And my
Yeah.
17-year-old is a trombonist. She goes to Cheetham School of Music, so she's really missing all the groups
Oh, I
and the
bet.
camaraderie that she has with her musician friends.
With them all. So, yeah. So your husband is
Yeah.
surrounded by all you girls and women.
He is, but it's hard for him because he's a surgeon and all
Surgeon,
his
isn't he?
being cancelled because of COVID-19, and he
So
has
have all like operations been cancelled then? Yeah.
A lot of the non-urgent ones have, but that
Yeah.
and you know it's having a massive impact. So they're trying to get back into some normality, but it's very difficult. You know, the sooner we can try and work out who's most at risk and who are low risk, it's going to, because this is having obviously a big impact on everyone, but for
everyone,
people who are ill and need help, need the NHS, you know, we've
I
got
know,
to help get these people managed properly.
Well, I hope we all get back and they all get whatever operations they need. But
so.
it was so lovely to see you, Louise.
Well,
thank you for bringing the time and
Megan.
coming
Thanks
on.
for all your work, because it's brilliant what you're doing. And as some of you might know, we've got lots of videos that Meg's in as well on the video section of my website. So they're all
please go and watch them.
I'm drip feeding them into Instagram, so it's another portal.
Oh, great. Okay, that's brilliant. Well, hopefully I'll be up there soon. I'll be coming and visit you again.
Definitely.
All right, lots of love.
Lots of love.
Thank you, Louise. Bye. Bye. Anyway, guys, so that was the lovely Louise Newson, all the way live from Warwickshire. Don't forget, you can download my app now. It's called Megsmenopause at Android or Apple. You can also track your symptoms on there. It's amazing. You can talk to other women. You can basically put your symptoms on there. It's on your phone. It's private. You can look at it. I post most days, and women can talk to each other about their symptoms. Anyway, I hope you enjoyed that chat, and I will be back with Dr. Harper for a coffee and a chat on Friday. Loads of love, everyone. Bye.